Hi everyone. I'm back to just share a little bit to conclude this segment about risk mitigation post-surgery. And this is based on our own experiences as to what happens and how to reduce risk in exposure to staff and surgeons post-operatively. I think a lot of what we're going to talk about has to be customized to the country we are in. In Singapore, we have a limited community transmission and very strong contact tracing abilities, which is why we are able to actually pick up cases relatively quickly and try to risk segregate them to which are high risk and low risk. So what I'm going to talk about now is actually in the next 2 or 3 slides is simply the context in Singapore. It may not be applicable to your country, especially if there's very widespread community spread unlike the situation in here where it's a little bit more contained. Well, I think one tip in risk mitigation and starts with prevention. And in prevention, I think the thing which is crucial is basically to try to identify these cases early. Now, we found that normal history taking tends to miss a lot of the contact and travel history and association, and even history of a respiratory illness, especially in the context of surgery, simply because patients don't think about that. They will be presenting with the abdominal pains and the other symptoms, and sometimes we have to assess at multiple time points and multiple periods to get this history of respiratory infection, fever, as well as contact and travel. So back in your own hospitals, make it a protocol that both at the emergency department and the general ward, at every point of patient contact, that you reassess this so that you can pick up cases and you don't end up with cases at the operating theatre door when you suddenly realize, oh, this is a patient who has got a significant risk and who I would have wanted to swab and perhaps even operate in a COVID theatre. So that's one. The second group of patients where we presume that they may have an infection until otherwise are sometimes those where we cannot get a history from. For example, in Singapore currently, we have an issue with our foreign workers and our construction workers all having a large spike in the number of cases. When patients come in through the door, let's say in the trauma situation, after road traffic collision, when we cannot get this history, we presume that these patients may be positive, may be suspect or positive cases, and we adopt a full PPE for these patients because we're not able to clear them with a good history and collaborative history. So this is one aspect in prevention. If you're not sure, presume the patient is. Second thing is, of course, and I think this has been discussed before, is first of all, review whether this patient actually needs surgery. There's a whole bunch of non-operative interventional radiology, pharmacological techniques that you can use to treat many surgical conditions, including appendicitis, cholecystitis. And in this period of time, consider whether in the first place you should bring for surgery. It's not business as usual. Try to see whether you should stratify your risk decision making. And the last part in prevention is make sure your staff, again, we've talked about PPE, time and again, make sure there are refresher courses. Even the elderly surgeons, people who have been operating for years, they may have forgotten, get them retrained. Now, what happens when you have a patient who's gone through the system, but you operated on them without the adequate protection, or you only realize that this patient has a contact or is a COVID positive patient after operating on them without the full PPE? What we do in our hospital is first, we activate our epidemiology and occupational health and infectious disease teams, number one, and we notify the Ministry of Health. A detailed contact tracing is done of the entire chain of doctors and clinicians and nurses and staff and porters and security who have been involved in the care of this patient, all throughout their chain from A&E all the way up to the ward and OT. And based on that, we assess what kind of PPE were they wearing. If a doctor was wearing appropriate PPE for that duration of the procedure, then they are just considered as a protected contact, and as such, they will still be allowed to work and just continue with temperature testing and clinical management and clinical monitoring. If they have not met the criteria, for example, they were not wearing PPE at all and encountered this patient and they operated on them, or they had them in the emergency department, or if they were doing an aerosol generating procedure and they were not wearing an N95 mask, for example, or goggles, then we would insist that these patients take a leave of absence with temperature monitoring and review of clinical symptoms. We don't swab them directly unless they become symptomatic, but we keep them away at work and we mandate that they don't turn up for 2 weeks until they are clear. So this is a very time-consuming and difficult process, but it's very important to limit healthcare worker spread. You really need to trace down exactly who has met the patient, and as well as what PPE they were using. And sometimes when there's recall issues, we presume that they haven't assumed that level of PPE. But if they have been providing the appropriate amount of PPE, and even if they operated on this patient not knowing that he was a COVID positive patient, we are happy, we trust our PPE, we're happy for to continue work. If not, you'll end up with quite a bit of staff loss and resource drain if you indiscriminately put everyone out of work as well. So this is a balance between continuing services as well as staff safety, and every institution has to review this and discuss it with their staff. If there's a patient that has slipped through the cracks, it's often useful to go back and reevaluate where this gap occurred in the whole system so that you can make adjustments to your system during this time of change. We also risk mitigate by segregating our staff. We maintain different teams which don't interact. So if we have 4 hepatobiliary surgeons, we have 2 on one team, 2 on the other, and they never interact and they don't meet, and they haven't been meeting for the last few months. While in order that in case one team goes down, we still have backup, and also not to deplete the entire capacity of our surgical team. Even within teams, we try to maintain social distancing. We maintain mask wearing in every part of the hospital, including the administrative and non-clinical areas, and we try not to break this team segregation as much as possible. And I think a part which we never think about much is also to monitor the overall workload and work strain, because people will start taking shortcuts, not wearing correct PPE, for example, when they are under strain and if they are overburdened. Regular surveys for burnout and for their own level of work is important, so that administrators and leaders can then make adjustments to the work processes. So this is a part which we don't really talk about, but it's really quite important. So these are that's all I have, and these are the main strategies that we use in my hospital. To conclude, misses will occur. There will be sometimes gaps and things will occur, and it's important that you talk to your departments so that they know that these are the plans to risk mitigate. When people are supposed to be at home, enforce it, make sure they don't come back. And again, the last point, limit the departmental effect of any spread with clear segregation policies and burnout monitoring. This is a complex topic, more than the scope of just these 5 minutes, but I'm happy to take questions in the chat, and I will leave my email there as well if you want to contact me offline with further questions. Thank you very much.